Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown.
This is the story of otitis media and sleep disorders in children. Dr. Travis Brown, is it okay if we call ourselves Wallace and Gromit for this episode?
I like the way you weave that in. We're talking about pediatric ENT conditions today, so excellent. Who's Gromit, though?
I think you're the star of the show, so it has to be you.
So, look, yes, we're talking about pediatric ENT conditions, just a few topics, and this is something that I'm sort of wanting to do more of, in the coming year. Talking to specialists, talking to physicians, and just go back to sort of some really straightforward topics and just say, hey, look, what's our understanding of this? How do we manage it? What's the best evidence? And so this is sort of a path that I'm wanting to go through, using pathology as sort of the basis. But again, every doctor learns about pathology, and everyone understands more than other people and can teach in that area.
And we've got Dr. Rowan Valentine, so happy enough to return.
Exactly. And this is the opportunity to say, hey, look, what's our best treatment in these areas? These are some things that are really common. And so, look, when we looked at pediatric ENT conditions and just ENT conditions, this is something we've always had. Like if you go back into ancient texts, you look at the Eber Papyrus in ancient Egypt, you have Mesopotamia, ancient, in those areas. Look, essentially their treatments, like if you go to ancient Egypt, they had a treatment which was topical ointments that had herbs, oils, honey, animal fats that you would put into the ear to try and soothe this. And Mesopotamia, it was onion juice, beer, sesame seed oil.
What's your opinion? Would they have worked?
No, well, you see, here's the thing: you would have had to have had it warm. And so our understanding with anatomy these days is that pain and heat travel along the same pathways. And so that's why it's actually like heat can be actually quite comforting during pain. So that's why people get, heat packs and everything, because it also interferes with the pain signal. And so that's why it's soothing. And so it would have worked for a sort of a semi-pain relief.
Almost by accident, because of it being warm.
Like an anesthetic type, and so it would have been soothing. It wouldn't have treated what it was there, but it might have soothed the pain. And this is the thing. Ancient Rome did it. Ancient India did it, where the, ghee or sesame oil, or the ancient Rome was rose oil and honey. But it was all just topical. And that's the amazing thing about this is, well, they wouldn't have had any other understanding of what was actually happening, because it wasn't until the 1800s that we knew the anatomy of the ear, because it's such a fine area. We're talking about sometimes the cochlea can be about 10 millimeters. And so our understanding of anatomy didn't actually come around until 1800s. We started to look into the ear in the 1300s, but that's with like a tong-like kind of thing that they would open it up. And the 1600s, that started to be refined. The 1800s is something that we would actually start to recognize as what we call an otoscope. But remember, they didn't have torch or light to be able to look in, so you actually had to use natural light to see in someone's ear anyway. And so this was actually a really hard area to visualize in a patient who was already coming in with a very sore ear, and then you're trying to open it up to look into it. And so that's where our understanding, and this is why I sort of, I know this is the misinformation age, but it's incredible how much information we actually have. Our understanding of anatomy and physiology, how hearing works, has all come together for us to understand this is what causes the pathology. And this is, we do have viruses and bacteria that affect our ear and our understanding. And so this now is where we're starting to go. And the problem with acute otitis media that we're going to be discussing is it's really common. And so that's the thing that we're going, well, how do we treat these patients, and how do we sort of understand what they're going through? Again, most parents will have actually seen it. We then have the progression, acute otitis media with effusion or otitis media with effusion. And so this is where we're coming today, and we're just going to discuss, glue ear, so the otitis media with effusion that stays around. But not only that, about sleep disorders in children, and understanding when is their behavior being affected, and how we all draw this together, again, to understand, help doctors, help healthcare professionals know these are the patients that need to see and will benefit from seeing an ENT. And these are the patients who we can say, look, we're just going to keep an eye on and it will probably fix itself.
And there is snoring within the children population.
And that's right. And it's about understanding when is snoring a problem. So snoring when someone has a cold or something like that, can be quite normal because it's inflamed. But if snoring when they're not, when they are well, then that can be a flag for people to say, we need to go a little bit further.
So if our wives ever question us and our snoring, we just say we're channeling our inner child. Dr. Rowan Valentine is a paediatric and adult ear, nose and throat surgeon who studied and trained in Adelaide. During his surgical training, he completed his PhD and spent a year at the University of Florida undertaking an anatomy fellowship. Rowan supervises surgical trainees and medical students and has a passion for working in rural areas. Rowan's a returning guest to this Medical Life podcast. Rowan, welcome back.
Thank you very much for having me again.
How common is otitis media in children?
So otitis media in children is really ubiquitous. So what I mean by that is that all kids at some point have suffered with otitis media. So an otitis media is actually a condition that has quite a diverse a group of definitions and pathologies, but probably what's most common to most people is the age-old ear infection. And what we call that, particularly in kids, we call that acute otitis media, which essentially means an infection of the middle ear. So that is very common. In fact, most children have suffered with an infection of the middle ear by the age of about 2 or 3 years of age. But some of these children suffer with recurrent middle ear infections or recurrent acute otitis media episodes. And they're the kids that sometimes benefit from other interventions to try and help with this disease.
Rowan, I want to ask whether this is a result of bad design or evolution on our part as humans, but perhaps that could be a preliminary opening to my question, which is the most common causes of otitis media.
Look, actually, Steve, I think you probably have a medical degree because you've hit the nail right on the head. So, unfortunately, whilst children are really cute and we think they're perfectly designed, unfortunately, their eustachian tubes are poorly designed. So, the eustachian tube's a tube that basically connects between the middle ear and the back of your nose, and its job is to drain fluid, to equalize the pressure in our ears. And as children, these tubes are very poorly designed. They're quite floppy. They don't open and close quite as well. They're at a slightly different angle to, say, the adult eustachian tube. And so these are some of the more common reasons why kids suffer with recurrent acute otitis media or glue ear more frequently than adults. So we really see this as a pediatric issue more commonly. So they're the fundamental reasons. And also, kids are also exposed to viruses. So they, particularly in the first few years of life, they get hit with a number of viral insults and infections, which again means that a eustachian tube doesn't work quite as well. So yeah, a classic pediatric problem.
You mentioned recurrent. Is recurrence just something, is there a medical term of recurrence, or is this just, the person gets a lot, they've got recurrent otitis media?
Yeah, that's a really good point. I think I'll probably define recurrent otitis media or acute otitis media as really any child that suffers with 4 or more ear infections in 12 months. So that's really where I consider it recurrent. And I usually consider it that way, because that, to me, in my mind, is something where we would consider a grommet or a ventilation tube. But grommet is probably the most commonly used term, which is a surgical procedure, a simple surgical procedure to pop a little sort of hole in the eardrum with a little tube there that allows the air to come in and out of the middle ear. And essentially, a grommet is something that bypasses the eustachian tube. So it's buying time until that tube matures like an adult. So so that's where grommets sort of fit into the pediatric group. So particularly in kids that are suffering with recurrent acute otitis media, it can be distressing for kids, it can be distressing for families, and that's where a grommet's a good option, just to buy a bit of time until maturity happens with the eustachian tube.
So looking at the actual sort of treatment of just an acute otitis media, do you recommend oral or topical analgesia for this?
This is a really good question. So if you have little Johnny with a stock standard acute otitis media episode, he's woken up last night with lots of pain. He's had a bit of a cold the last few days, but now this morning he's actually seeming a bit better. He's eating and drinking and otherwise pretty well, except for a runny nose and a snotty nose, etc. Then there's no evidence that any treatment for acute otitis media will make any difference for little Johnny. And what I mean by that is you need to treat about 15 children with a full course of antibiotics. So that means every one of those 15 children have had their sort of week's worth of oral antibiotics, and only one of those kids will have any benefit at all, and that benefit will be about half an hour of less pain. So, you've got a huge group of patients being treated with antibiotics and having very little effect on the overall outcome of the condition. So the general recommendations for little Johnny, particularly if he's over the age of 2, is 48 hours of observation. And if he's no better, then antibiotics. Now that's different in the Aboriginal and Torres Strait Islander population, and there's we're a bit more conservative in those children under the age of 2, but that's the general principles of treatment. So observation is generally what we recommend, and a lot of parents have already worked that out, particularly if they're suffering with recurrent infections.
How does the under 2 change?
Under 2, well, the medical literature has only really been investigated in 2 and above, so there's really a lack of evidence in the under 2 age group. So we're a bit more cautious in our recommendations, but it probably, even in under 2s, it sits in the same poor evidence for antibiotics.
Now, there is now I can't say this,
At last.
Tympanocentesis, so that's putting a needle into it. Gee, it's been a while since I've had to say that. Where you actually perforate the eardrum. Now, this is clearly when it's been bulging and, it may relieve the pressure and sometimes this happens on its own. But when is this recommended for a doctor to do this?
So in the pediatric population, it's really never utilised, to be honest, because you have to have a child under an anaesthetic. And if you're going to have a child under an anaesthetic for tympanocentesis, then typically you're putting a grommet in, essentially. So we don't usually do this procedure in children. In adults, there are ways of doing it in adults. However, it's very painful, and local anesthetics, so anesthetics where you just put a few drops in the ear or some cream in the ear to numb the ear, are generally not very effective in the acute otitis media episode. So again, you're usually taking patients to theatre in the acute infection scenario. So really, actually, tympanocentesis is not something we use. We might use it if we're trying to aspirate some fluid to find out what that fluid is. But it's very, very rarely performed, to be honest.
And what's the common time to resolution for otitis media?
So acute otitis media, usually kids will be much better within sort of 48 hours in terms of their pain has gone. But now we're going to lead into a condition called glue ear, or otitis media with effusion. So So that's often the sequelae of an acute infection. Patients are left with just fluid in the middle ear. Now, that's not infection anymore. It's just the residual inflammatory changes after the infection's resolved. So the time frame for that fluid in the middle ear to resolve is usually about, well, almost always within 3 months. So, and usually a lot quicker than that. So what I mean by that is that little Johnny's infection is now resolved, but he's finding it a bit hard to hear around noisy environments, or is having to ask things to be repeated often, with a bit of hearing loss, temporary hearing loss, and that will usually resolve in 90% of children within 3 months, but usually a lot sooner than that.
Is there any trouble with the anesthetic in the ears when you do the drops for someone with an acute otitis media?
No, there is no problem in using those sorts of analgesic regimes. I suppose sometimes there's other things in the ear canal that impede the ability for those to work, like wax, for instance, or it may make wax as a solid material. It can make the wax into a runny liquid, which then can coat the eardrum and then sort of temporarily cause hearing loss. So some of those sort of interventions in the ear canal can have their other problems. So typically, I just recommend Panadol or Nurofen in the pediatric population for that sort of stuff.
It does sound like pulling a loose thread on a suit.
Yeah. Yes.
Now, is there such a thing? I know we're saying acute otitis media. Is there such a thing as chronic otitis media?
Yes, there is. So that's a really good question. So chronic otitis media is actually a broad umbrella term that that really means a hole in the eardrum. So I think that's probably a layman's way of describing it. So a hole in the eardrum that's been there for more than 3 months is chronic suppurative otitis media. That's the medical terminology. And that can then be determined whether it's active disease, that means it's leaking pus all the time, or inactive disease, meaning the ear is actually really healthy, it just has a hole in the eardrum. So that those two sort of situations sit underneath the chronic otitis media. And these sorts of conditions occur particularly commonly in the Aboriginal and Torres Strait Islander populations, or population of patients.
Is there any children who are considered more at risk for acute otitis media?
Yeah, there are. So there are some risk factors for it. Being a child is probably number one.
Yes.
Having many children in the family or a few children in the family, so that's certainly a risk factor. So you often see a number 2 or number 3 child. Immunization status can sometimes have an influence as well. Overcrowding living situations can sometimes be a factor. Childcare, obviously, because it's a bit of a mixing pot of viruses, the childcare environment. So definitely that can be a factor. Obviously, having parents, for instance, that may smoke in the family can also be a factor too, because that affects the some of the immune functions of the middle ear. So they're probably the most common risk factors that we see.
Now, we've mentioned antibiotics. So when is it appropriate for antibiotics to be actually prescribed for these patients?
So when patients are failing, so firstly, if the patient's particularly unwell, if they have a febrile, nausea, vomiting, so an unwell child then we would probably go straight into antibiotics, recognizing the limited efficacy of antibiotics. If the child fails to improve over 48 hours of observation, then we would recommend antibiotics for acute otitis media or the acute ear infection.
Is the management any different for children who have already perforated?
That's interesting. So sometimes kids will perforate their eardrum as part of the sort of natural resolution of the infection. And that's because pressure builds up in the middle ear and the pressure has to get out somehow, and that's how the eardrum ruptures. And effectively, it's really the body sort of treating itself, to be honest. As soon as that eardrum ruptures, their child's pain is typically gone, because pain is caused by the pressure in the middle ear. And so once the eardrum ruptures, that pressure's gone. So it's actually an immediate relief of the pain when the eardrum ruptures. In that setting, I generally recommend keeping the ear dry, because getting water in the ear canal could potentially go into the middle ear and cause persistent issues and inflammation. So I keep the ear dry. In the ear, nose, and throat setting, I'll often actually use some topical ear drops. So I might use some Ciproxin HC ear drops, typically in that setting, only because we have now a direct port. But otherwise, that would be all. And then following up with the patient just to make sure the hole healed, and be mindful that most of the time the hole heals. So I always reassure parents, because it can be quite alarming, or they've got a hole in their eardrum, or what does that mean? I always reassure that generally will resolve by itself.
And when is it appropriate for a child to be referred to an ENT surgeon?
Yeah, so I think when it comes to otitis media, recurrent acute otitis media is important to be referred for consideration of grommets, and that's really a quality of life question. Patients don't have to have grommets in that setting. It's just about trying to improve the experience for child and for parents with those recurrent infections. The other thing is otitis media with effusion. Now, we define that as having that fluid in the middle ear without the infection that's persistent beyond the 3 months. Remember, I reiterated that most of the time it will go away, but sometimes it won't. And so if you have fluid in your middle ear that's been present for more than 3 months, then that's when we would recommend grommets, because it's unlikely that with further observation that fluid will go away by itself. So after the 3 months, that's a really important point for referral for a grommet to be placed.
Rowan, you've mentioned glue ear a couple of times. We're going to pause very shortly and come back and do a bit more investigation there. But before we leave otitis media, any final thoughts for doctors about children with recurrent otitis media?
No, I think we've probably summed it up pretty well. I don't really think I've got much more to say on that.
And parents, I feel for, because they've got to hold their nerve for that 48-hour window when everything in our society says, take a pill, take something, get it fixed.
Yes, absolutely. That is a really tricky thing, isn't it? And often parents' experience is they've whipped the patient straight off to the GP. They've got antibiotics, and then 24 hours later they're better. But what happens is they didn't whip the child off to the GP, didn't get antibiotics, and 24 hours later the child was better. So, it's that sort of self-fulfilling prophecy.
We continue now with Dr. Rowan Valentine. And Rowan, as I alluded to, we're looking at glue ear in this segment. How common is otitis media with an effusion in children?
So otitis media with effusion, again, is very, very common. In fact, I think most parents are probably may not even be aware their child's been suffering with it, because, our body was designed with 2 ears, and we can actually hear really well with just 1 ear. So you don't actually need 2 ears to hear well. You do in a few situations. So when there's a lot of background noise in the environment, you need to have 2 ears that are hearing at the same level to be able to pull out what someone's saying to you when the room's noisy. So now it can be quite easy to miss that in a child when there's lots going on. So, and the other time when you need 2 ears, if you're trying to work out the direction of sound, where sound's coming from. So that is the disability of having just 1 ear that hears. So it's only a mild disability. So I think there's lots of parents that have missed glue ear in one of their children's ears. If it's affecting both ears, it becomes then more obvious. So because little Johnny now can't hear anything even when it's quiet, or can't hear much when it's quiet. So Yeah, so I think again, most kids have suffered with otitis media with effusion or glue ear at some stage in their life.
What is actually the effusion?
So that's a good question. It's essentially just inflammatory fluid. I always try and stress to parents that it's not fluid or water from the bath or from the shower or from the swimming pool. It is inflammatory fluid that the body has secreted into the middle ear. And that fluid can be really thin and watery, or it can be really, really thick and mucousy, which essentially underlies the term of glue ear because it can appear like glue in the middle ear. And it can be very hard to suck out sometimes.
How common is recurrent otitis media with an effusion?
Like recurrent otitis media diffusion is common as much as recurrent acute otitis media is as well. So, because it's often the sequelae of that acute infection. So, it is common. More commonly, however, is chronic otitis media with effusion, or essentially fluid in the middle ear that's persistent beyond the 3 months. So that's a very common reason for intervention in grommets. And in fact, unfortunately, in that particular setting, there has been no evidence that any treatment or conservative treatment like blowing your nose or valsalvaring or trying to pop your ears or antibiotics or nasal sprays or any of those things there's no evidence that those things make any difference. So in the chronic otitis media with effusion situation, we generally always recommend grommets.
Well, what is the complications of acute and chronic otitis media with effusion?
So the complications essentially really are hearing loss. So because you're essentially hearing underwater. So that's the number one issue with chronic otitis media with effusion. Sometimes you can get some changes to the eardrum where the eardrum becomes really floppy and gets a bit sucked in because it's under stretch all the time, and that can potentially lead to hearing loss and other changes to the middle ear as well. So, untreated chronic otitis media with effusion can lead to both a temporary and permanent hearing loss in the very long term. So we generally recommend intervention.
Is there some people at risk of glue ear that doctors should be recognising to check?
Yeah, so in the general population, I suppose kids with recurrent ear infections are at risk of glue ear. The risk factors also include the same risk factors for acute otitis media, which we talked about. So childcare, number of kids in the house, smokers in the house, etc. But also we have a subgroup of population, particularly again Aboriginal and Torres Strait Islander patients that are particularly at risk of glue ear as well. And we don't really understand the reasons for that, but there may be some genetic basis to that too. So certainly those populations are particularly at risk.
Is there a requirement, or is there some guidelines to say who's required for an urgent referral for an ENT review?
Anyone that's essentially had otitis media with effusion for more than 3 months should require an urgent referral to an ENT surgeon. Any child with a language delay or speech and language delay, now those children don't necessarily require an ENT referral but require a hearing test. So a hearing test is first and foremost for those kids. And then if there's an abnormality to that, then they should be referred to an ENT specialist.
Now, you've mentioned grommets. Is there any other interventions available for managing this?
Yeah, so that's interesting. So grommets are certainly the mainstay intervention for otitis media with effusion. Now, having said that, there's a slight difference in Aboriginal and Torres Strait Islander patients because sometimes grommets will be used in these patients, but they have a much higher risk of a perforated eardrum with the use of a grommet in the Aboriginal and Torres Strait Islander populations. So that's the last thing we want to happen after an intervention because that can lead to hearing loss. So in Aboriginal and Torres Strait Islander patients, sometimes we'll treat things slightly differently, which involves a myringotomy, which essentially is making a little hole, temporary hole in the eardrum, sucking out the fluid. And we would also do an adenoidectomy. Now, an adenoidectomy is removing the adenoids that sit at the back of the nose where the eustachian tube opens up. So, and that combination of treatment in the Aboriginal and Torres Strait Islander patients has been shown to be effective. So we just change traditional treatment paradigms in that population.
What can and can't children do when they have grommets?
Oh, that's a really good question. So we've probably seen a bit of a generational change. I'm sure we are all aware of some kids having grommets and being told they can't go swimming, they can't get their ears wet, etc., etc. Whereas we've sort of worked out really over the last couple of decades that that advice may have actually been incorrect. And swimming with grommets is actually a low risk activity. So even if you did get water into your external ear, the grommet is so small that it's unlikely that that water would go into the middle ear, because of the surface tension of the water means that a small hole, it's unlikely for the water to go through that small hole into the middle ear. Now, that's different if you're doing deep sea diving and there's lots of pressure forcing that water in. But for most kids just swimming in the backyard pool, it's unlikely to be an issue. And the same for baths as well. Although when you've got bubbles in the bath, it breaks down the surface tension, and in theory, then there could be water going into the middle ear. But my advice to my patients is not to worry. Keep the ears dry for about 2 weeks after the surgery, and after that, kids can get their ears wet. And I'm sure if you've got kids yourself, it can be hard enough to get kids to wear a hat, let alone to wear some earplugs and a swimming band. So, yeah.
Yeah, is there a risk of recurrence when grommets are removed?
So grommets aren't removed. So grommets actually come out by themselves. So the eardrum will actually spit the grommet out, and the average is about 9 or 12 months after they go in. That's for the average grommet. There's different types of grommets, but for simplicity, we're talking about the short-term grommets. So yeah, they come out by themselves. Now, unfortunately, it would be great if the body decided to get rid of the grommet when it was no longer needed, but that's not how it works. The grommet typically comes out 9 or 12 months, whether it's needed or not. And yes, there is a chance that another grommet may be required after that grommet comes out. Typically, we say if little Johnny's station tubes are so poorly functioning that little Johnny needs grommets or requires grommets before the age of 2, then there's about a 50% chance that they'll require another set of grommets down the track. So yeah, so if it's an older child and it's their first set of grommets, it's probably unlikely they'll need another set, but we keep monitoring for it. If they're under the age of 2, there's a 50% chance they'll need another set.
Rowan, I'll put you on notice that if I get involved with AI and we're going to create a new species, we are having an immediate meeting about the whole ear area.
Great idea.
Yes. Have you got any final thoughts or advice for doctors about children with OME?
No, I don't think so, except just to be vigilant and mindful about that child that is struggling in noisy environments or having to ask for things to be repeated, just to be mindful of that diagnosis, and it can often go undetected.
We have one last stop before we let you go, and that is about children with sleeping disorders. So let's just take a moment to reflect on that. Dr. Rowan Valentine, thank you for staying with us. We have a different area where you ENT people are involved from time to time, and that's children with sleep disorders. Can you tell us about this? How does that happen in children?
Sleep disorders, or maybe what we should say is sleep disordered breathing, is really the collective term that we're using here. And that is really any child having difficulty breathing during sleep. And actually it's really, really common in children. So, and it can range actually from all the way from the snoring child all the way to the other end of things where the child's actually stopping breathing during their sleep or having what we call apneas. So it's a very common entity. And in fact, if we look at the majority of children that require a adenoidectomy and tonsillectomy, the majority of those cases are happening for sleep disordered breathing. And it's a really, really important issue. And it's an issue that is completely underdiagnosed by not just in the general population, but sometimes in the medical fraternity, it can be underdiagnosed as well.
This is fascinating about children snoring, because in our common culture, we don't expect that to be the case. And my kids would make fun of me hearing me snore. And I think, well, I can't really throw the stone back to them. But is it actually common?
It's very common. It's very, very common. Up to maybe about 25% of the pediatric population snore. So it's exceedingly common. And we need to be, that doesn't mean that every child needs treatment for simple snoring, but we need to be mindful about looking for the at-risk child. So I think the old adage that snoring is not normal in children is a really good general principle. It should prick our ears up to think, okay, little Johnny's been snoring even when he's well. I'm not talking about when they're sick, but when they're not sick and they're snoring, I think, okay, maybe we should look for any other things that might make us concerned. So some of those things might be that little Johnny's irritable or moody or has poor concentration or hyperactivity. And some of those behaviours may not be normal. He might be bedwetting, where he never used to bedwet, and that can be an important symptom. He may be particularly sweaty in his sleep, and that means his body's working really hard to sleep, and so that's not normal either. And there may be things like what we call apneas, which is pauses in breathing when Johnny's sleeping. So there might be a smooth snoring, and then all of a sudden that snoring stops. And for about 5 seconds, 6, 7 seconds, there's no breathing at all. And then there may be a gasp or a sudden sort of let go, and now he's breathing again. That's what we call a apnea or hypopnea. So pauses in breathing. So they're some of the really important things to look out for.
So aside from parents recognizing snoring, is there any way to know how someone might will benefit from either discussing with a doctor or an intervention?
I think having a low threshold for discussion with a doctor when anyone's snoring, I think, is the first thing I would say. Now, like I said, most of those kids may not need any intervention whatsoever unless they have any supportive symptoms, like I've sort of just mentioned previously. And the difference between, I think I'm answering your question, correct me if I'm not, but the difference between adults and children is that children typically have what we call adenotonsillar hypertrophy, which means their tonsils and their adenoids are big for the relative space in their throat, whereas adults don't typically have that problem. Adult snorers don't typically have that problem. So pediatric snoring and obstructive sleep apnea is actually easily treated surgically in a child with big adenoids and big tonsils, whereas the adult is not quite the case.
Is it easy to determine if a child has hypertrophied adenoids and things?
It actually is, to believe it or not. So it just requires a simple inspection of the back of the throat for a child, and sometimes children are willing to partake in that examination, sometimes they're not. But we do have various ways of being able to coax kids to open their mouth so we can have a look at their tonsils. And we grade tonsils from grade 1 to 4, essentially. And essentially we consider enlarged tonsils as grade 3 or 4. So grade 3 size tonsils is when the tonsils are encroaching on the uvula, which is the dangly bit at the back of the throat, but they're not touching each other. And grade 4 is when those tonsils are actually touching each other. So so that's pretty easy to look at the tonsils. But the other issue, it may not be tonsils, it could be the adenoids at the back of the nose. Now, that is not quite as easily examined in the office, And for those kids, I do a simple X-ray, which is a X-ray on the side of the head. We call it a lateral X-ray, and it's literally just a photograph is taken, and you can see the shadow of the adenoids at the back of the nose. So that's a really useful tool in young kids. In older kids, sometimes we can pop a little camera in the nostril called a fiber optic endoscope, and we can see those adenoids. But I wouldn't typically try that unless the child was 10 or more and particularly cooperative. So yeah, but there's some simple ways of determining that.
And the treatment, what's that like with regards to removing them?
So we call it a adenotonsillectomy, or sometimes we actually use what's called a tonsillotomy. So an adenotonsillectomy is a good option. We particularly would do that technique if the child was also suffering with tonsillitis, so where we remove the tonsil. Whereas if a child did not suffer with tonsillitis and it was just the snoring or obstructive sleep apnea, we may look at the option of a tonsillotomy. Now, a tonsillotomy is, for want of a better word, just shaving the tonsils away. So you're basically debulking or removing 90% of the tonsil tissue. Now, the advantage of that is the recovery is a little bit easier. But typically, kids will suffer with about 10 to 12 days of a sore throat, which Pano and Nurofen usually manages relatively well for that population. I always tell my patients they can eat and drink anything after the surgery, so there's no foods they need to avoid, except for maybe acidic substances like, say, orange juice. But otherwise, they can eat and drink anything. But drinking's more important than eating, just so they don't get dehydrated afterwards. But kids generally manage this sort of thing pretty well.
What's the success rate like with regards to resolving the snoring and the sleep issues?
Over 90%. So in the right child, that is, so the child with big tonsils or big adenoids, it's over 90%. So a very effective treatment option. There's a very small subgroup of kids that may have a number of other reasons for their obstructive sleep apnea, a number of medical issues, say neurological issues or developmental issues. They may have particularly floppy muscles, for instance, or hypotonia. There may be other craniofacial features that make them at risk of not responding quite as well. So a small jaw, for instance, which may contribute to a collapse of the tongue when sleeping. But there's a minority of patients, and over 90% of patients respond well.
Rowan, do you have any final thoughts or advice for doctors about sleep disorders in children?
Yeah, so my final advice for sleep disordered breathing essentially is snoring is not normal and probably warrants a medical review, and that can be simply seeing your GP for an assessment of the tonsils and adenoid size and any of those other symptoms of sleep disordered breathing more than just snoring alone, and then obviously referral to an ENT specialist if there's any concerns. So I think fundamentally sleep disordered breathing is probably underdiagnosed in the community, and if there's any concern, definitely seek advice through your GP for further clarity.
Given that in most families we kind of laugh it off or would joke about it, is there a cause for proactively probing a parent with children, even if they're not presenting with it, just in case? Is it at that level?
Yes, I think it is. I think a simple screening question is, does your child snore when they're well, is probably all that's required. And I think fundamentally the reason why snoring is a problem is it affects neurological development, heart and lung development. It affects academic performance, concentration in classrooms. It has significant implications on childhood learning and development. So picking it up early and treating it appropriately is really fundamental to the management.
Wow, you know how to turn it from a joke to something serious. Dr. Rowan Valentine, thank you once again for joining us here on This Medical Life.
Not a problem. Thank you very much for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.